Welcome to My Care Alliance podcast. My name is Ann Llewellyn, and I will be your host for today. Today, we are going to talk about Medicare. Many of us look forward to going on to Medicare. What most people find is that it's a complex and confusing process. To help us understand the process a little better, we have invited George Kraft and Michael Gennati of Senior Benefits Alliance based in Louisville, Kentucky, to give us some insight into questions that many of you will face as you go on your journey of considering Medicare. Also joining us is Ginger Jones of My Care Alliance. Welcome, everyone. Thanks for coming on today, George and Michael. Can you give us a little insight into what you do at Senior Benefits Alliance?
Absolutely. So, Senior Benefits Alliance is an insurance agency that focuses entirely on the Medicare population, Medicare benefits, Medicare options. Our specific niche is that typically we don't market ourselves or our agency very often. Our biggest referral source is medical providers. So typically medical providers send their patients to us for assistance with some type of access to care, whether that be a primary care physician, home health agency, surgeon, hospital network. A lot of social workers utilize us, but it's patients that are needing assistance accessing some sort of care. So that's our specialty, is understanding how Medicare works for both the patients and the providers, and then connecting them to the care that they need. So usually we kind of play middleman or quarterback to try to fit the patient to the providers and take all the needs into account. And we're brokers, and we try to be as non-biased as we possibly can to advocate for the patient and the provider.
Wow, that's interesting, and that especially that you really look at what type of coverage would be best for the person so they can get the best providers. I think that's something that not a lot of people think about, but how important is having that policy that will really give you the most choice when you have a medical condition, or just even to keep healthy. If you're a healthy person already, we want to stay healthy. So that's very interesting. It's a unique position. So here's our first question. Who's eligible for Medicare?
You want to take this one, Mike?
Yep. So Medicare is going to be opened up to usually people turning 65. That's the typical enrollment population. There's three other ways that people would be eligible for Medicare. That's receiving Social Security disability income payments for at least 24 months. On their 25th month of receiving that SSDI payment, they're automatically enrolled in Medicare Parts A and B. The other option would be end-stage renal disease. People with that are automatically enrolled in Medicare. There's two windows for enrollment there. If you're on dialysis, your Medicare enrollment would start 4 months after dialysis has started. The other option would be the month that your kidney transplant takes place. If there's some medical work that needs to happen before that, it could be up to the 2 following months there when your Medicare A and B start. The last one would be anybody with ALS or Lou Gehrig's disease. They're eligible as soon as they receive their first disability payment from Social Security. So those last three, you would have to reach out to Social Security and actually apply for Parts A and B. But then once everything's approved, they start, the months that I had mentioned there.
Okay. So it isn't just people at 65. And I think for our audience, for care managers, for patient advocates, that's important to know that there are other ways that they can access Medicare. They can be eligible for Medicare. So especially, I think I have a friend who has ALS, and she hasn't wanted to go on disability. She hasn't wanted to
Mhm.
because she was actually still working when she first was diagnosed, but as the disease progressed, but I don't know if, now that she can't work, she doesn't have income. I don't know if the college is going to continue her Medicare, continue her insurance, health
Yeah.
insurance. So, do you advise people like that if they have, like, when do we make these decisions? When is it? I think that's what people really need help with is you get a diagnosis like ALS that is really, it's a life threatening condition. There is no cure for ALS. And how do they know? They want to keep going, so they keep working, but would it be beneficial for somebody to go on SSDI so it puts that process in place to be eligible for Medicare early?
I would personally, if it were to be a family member of mine with a end-stage renal diagnosis or an ALS or Lou Gehrig's diagnosis, personally, I would always assist the family member in applying upon diagnosis for SSDI. There's no harm in it. Should they be able to say they get approved for SSDI and they can continue to work beyond SSDI approval? We have a Social Security resource that we would reach out to definitively answer this question on how it works. But my understanding is that should their income continue beyond their approval for SSDI, is that there is an income offset there. So that they're not going to be doing anything wrong. They're not going to be abusing the system. But should the work stop, we definitely want the Medicare benefits to be in place to provide the care that's needed right away, if possible. And then it can also be confusing to the dialysis patients or the ESRDs if they have a successful transplant or if dialysis stops for whatever reason. If dialysis stops, it's 12 months after you've ended your dialysis, your Medicare can come to an end, and 36 months after a successful transplant. So they can do follow through care, make sure they properly recovered from the transplant. It's continued to work for 36 months. We do get calls from time to time where Medicare benefits have ended and they don't have a full understanding or comprehension as to why. So that's one to keep note of. And then the ALS, Lou Gehrig's, when you apply for that Social Security disability, generally speaking, those get fast tracked to where that, if you have a diagnosis in your medical records showing that you do in fact have those conditions, you typically can get set up pretty quickly for SSDI and your Medicare will start in conjunction with it.
Yeah. Is cancer one of those fast track diagnoses?
No.
Nope. Those are the only two or three if we're differentiating ALS or Lou Gehrig's, but
Okay.
two scenarios there.
Okay, thanks. So for someone who, many of us are continuing to work after 65, we're not ready to retire. We like what we're doing and we want to stay working. So many people say, well, why should I get Medicare? I'm going to continue to work. So what would you say to a client like that? Should they do anything at this point?
Yeah, we run into that scenario very, very often. And there's not a perfect answer for this, but I'll do my best. So it is a little contingent upon where they're employed and the type of group benefits they have. So whether or not it's a small group or a large group, and whether or not Medicare would wind up being your primary coverage or secondary coverage can dictate whether or not you have to enroll in Medicare at age 65. So if you have a human resources someone available to speak to, I always recommend that, to talk to them about how the group is structured and can you continue to be on the group and defer your Medicare Part B.
Yeah.
So whether or not Part B can be deferred is crucial. And you will also want to ask that human resources person whether or not your coverage is credible. So your coverage needs to be credible. And if it is, and they allow you to continue to be on the group beyond age 65, you're good to forego Medicare. You put your Medicare Part B in deferment and continue on with your group until you decide to retire. When you come off of the group, you can put your Part B in place and go on to Medicare. There are scenarios where you do have to take Part B, and if you do have to take Part B, then you still have the option to stay on the group. You want a thorough analysis. It's always going to be apples to oranges, but you want to try to find a non-biased resource to help you compare cost and benefits with your group versus cost and benefits with Medicare, Medicare Supplement, Medicare Advantage. You want to compare it all as best you can. It's always going to be apples to oranges. I know that's a long-winded answer, but it's a combination of a non-biased resource and human resources department coming together to get the right information for someone to make that decision.
And I'd like to add too, another piece that might be an important factor to consider is that person's spouse on that group insurance as well. Because if they have to leave, their spouse might not have coverage until they're Medicare eligible, or then we're looking at individual marketplace insurance or short-term insurance, something to kind of bridge the gap. That's a very important thing to consider. Sometimes when the employee leaves, they won't keep the spouse or the family on the plan. They'll have to go when the employee leaves the coverage as well. So that is another important piece to consider as well. On staying with the company insurance while you continue to work, or coming off for Medicare and having Medicare be your primary.
And there are groups or employers that have set it up both ways. So there are instances where, say the husband is 65 and the wife is 63. There are instances where a group will allow the husband to come off and the wife to stay on until she hits that Medicare eligibility age. And there's other ones where if the husband comes off, the wife's coming off too. So you would, in those scenarios, husband would stay on to age 67 so that they both are properly aged into Medicare, and then they come off of the group together. So hopefully all of that, thanks for pointing that out, because that definitely is very important.
That's an important piece because no, if the husband is like an executive and making really good money and the wife didn't work, she's on his policy, the kids are on his policy, and they have to all look for new insurance.
Yep, absolutely.
Yeah, that's a good point. I really never thought of that part with this decision. So here's the $1 million question. Is there a cost to Medicare? I think a lot of people think Medicare might be free.
So with Part A, if we've worked for 40 quarters or more and paid our Medicare taxes annually into the system, as long as we've paid the Medicare tax for 40 quarters, we are going to qualify to have Part A. So it's not that it's free or no cost, it's that you've pre-funded your Part A payment in your Medicare taxes that you paid while you worked.
So it's not what do they call it? It's not a benefit. We have paid for that.
Yes.
Correct. Absolutely. If you look at your tax return every year and you see that you've paid some sort of Medicare tax, yes, you've pre-funded it, as we like to say, rather than it's free.
I think you guys have to get on CNN and stress that.
Yeah. Well, that's why too, when people turn 65, they are automatically enrolled in Part A. You actually have to go out of your way to decline Part A enrollment. You'll get a Medicare card with your name and Part A and your Medicare number. So you'll get that automatically.
I think a lot of people think that's just from AARP, but it really is from Medicare automatically.
Yep.
I think a lot of people, in my experience, don't understand what Part A actually gets them, which
Yeah.
isn't a whole heck of a lot. Can you all speak
We
to
got
that? I mean, they get Part A, so I mean,
Yeah, what does that mean? What does Part A mean?
So in short, Part A is your hospitalization coverage. So we refer to it as your room and board coverage. So 4 walls around you, a roof over your head, a bed to lay in, and any durable medical equipment that might be used while you're in the hospital. It does not cover your physician services or medications while you're in the hospital. Those fall under Part B. So Part A, you'd look at it like renting a hotel room. It's your room and board, essentially. It works in 3 different tiers. So upon admittance, you have a copay for up to day 60, which do we have the most recent one? Yeah, $1,484 copay that's going to cover you from day 1 of your admittance to day 60. So it's a flat copay. So if we're in there overnight, $1,484 is a pretty expensive hotel room. If we're in there for 59 days in a row and we're discharged on day 60, and you break that down per day, the $1,484 isn't so bad. Beyond day 60, with original Medicare being in force as your primary coverage, especially if it's your only coverage, if you're in the hospital beyond 60 days, that's when we go to a per day deductible. And now you're on the hook for $371 per day from day 61 to 90. And then day 91 to 150, you owe $742 per day. So we get to a really expensive hotel room. And then beyond that, we have no coverage in the hospital with original Medicare. And days 91 to 150 are also referred to as our lifetime reserve days, or LRD days for short. All that means is that if we ever use them, we lose them. Odds are, hopefully none of us are going to stay in the hospital for more than 90 consecutive days. But if you do, starting on day 91, as you use it, you lose it. If that makes sense. So if I'm in the hospital for 100 days, I'm going to use 10 of my lifetime reserve days. If I'm discharged and then readmitted in a few months, I'm starting over at day 1, but I've got 140 days of hospitalization coverage instead of 150, having previously used 10 of my lifetime reserve days. So,
and outside of hospitalization, Medicare A will pay for some qualified, like long-term or rehab fees on a limited basis as well. Is that accurate?
They'll cover some
we got a list.
home health care. They get hospice is covered 100% through Part A.
Well, throughout the conversation, we'll reference a piece called Medicare Made Clear.
Yeah.
It does a good job of defining a lot of the specifics to our conversation. It is from United Healthcare, but the information in it is very generic. But it will display exactly what benefits are and can be covered by Part A. And then the same with Part B. It's got a page that speaks to it very clearly. We're searching for it now, but oh, there you go.
Yeah. So Part A is gonna include the room, like George said, the meals served to you at the hospital, skilled nursing services, care and special units like the intensive care unit, lab tests, X-rays, medical equipment as an inpatient, the OR or recovery room services, some blood transfusions.
I misspoke. The medications are covered under Part A.
In the hospital.
In the hospital.
Correct. Yeah, sorry.
Not
Please.
when you go home, right?
Yes. As an inpatient, Part A covers your medication.
And then part-time skilled care for homebound patients after a qualifying inpatient stay. So that would again be the 3-day stay or more.
So Medicare Part A covers those things. And did you say there's a cost from 0 to 60 per day? $300 and some dollars?
No, for 0 to 60, it's a flat deductible to cover the whole window of day 1 to 60. From admittance up to day 60, it was
$1,484.
Wow.
So mathematically, you could get hit with that $1,484 deductible 5 times in a given year, if I'm not mistaken.
went out
If
and
you
came
were
back.
terribly unlucky and timed it out just right, you could get hit with 5 of those deductibles.
But that's still a lot of money that I don't think people realize is part of it. You know, we don't really know the true cost of any part of healthcare. Really. I think
Yeah.
that's probably the biggest challenge that we all of us have in healthcare is what does it cost? And this has been enlightening because I really didn't realize that there was those costs associated with it either. Oh, brother.
I think when I first became aware years ago with my care management business, I was working with a client that had an extended stay after a hospitalization in a nursing home, and they didn't realize that they had accumulated like $11,000 in co-payments because they weren't aware that they had a portion to that. And at this time, they didn't have any Medicare. This particular customer I was working with didn't have any supplement. They weren't on an Advantage plan. They really just, had the bare bones. So
Yeah.
that really opened my eyes years ago. And I started realizing that there's a lot of options and
And there's a
factors.
lot of hidden costs, I mean, is that written out in this Medicare Made Easy? That's where you got this from. So that's a really important document. All care managers, patient advocates should have on their desk probably. We really don't, I mean, I don't know why it's not that it's a secret. It's just not talked about. Even I don't know if doctors, that's why your company that works with providers and patients, it's important that we have that because we say, well, why would the doctor order that if he knew he probably didn't know you didn't have coverage.
Well, and he doesn't know.
They don't know what it costs.
Yeah, and you think every plan's a little bit different, and that would be impossible for a doctor to know how each insurance plan works in each scenario. So
Yeah.
he knows that you have insurance, but he doesn't know what your insurance covers or what requisites are needed for certain aspects of care. That would be a lot of information for your doctor to know.
Wow.
Also in the Medicare Made Clear, I'm not certain on the page number, we'll have to find it, but there is a good page that also references what's not covered by original Medicare. And it's got a good pointed list, such as custodial services or long-term care needs. Added benefits are not covered by original Medicare, like dental, vision, and hearing. There's a pretty good list there. Another pet peeve of mine is when people tell me that they have Medicare and it covers everything.
Yeah.
Obviously, that's
Well,
not the truth.
but I think people do think that.
Yeah.
I really do think they do think that. And
Yes.
that's the problem.
And George, when you say original Medicare, you're not referring to just Part A, you're referring to Medicare Part A, B, and C. Provided, is that accurate? Because we were talking about just Part A.
Just
but-
A and B, A and
So
B.
correct, A
Okay.
and B. So I would never recommend in any scenario that somebody walk around being covered by just original Medicare or Part A and B only, because you have unlimited liability financially. You are exposed there. You do not have a max out of pocket. There is no limit to how much you can be liable for. Now you are protected per claim. So per medical claim, you are protected by Medicare assignment. So Medicare only pays so much per claim, and the Medicare eligible is only responsible for 20%. But how many number of claims you have and what they can add up to in total is unlimited with original Medicare. So we're not a big fan of seeing people have just original Medicare. It's always recommended that they seek out a supplement and a drug plan or a Medicare Advantage plan Because oftentimes they can find added protection at no additional cost to their original Medicare benefits.
Wow. Okay, so are there any other choices to traditional Medicare?
No, so once we decide we're going on to Medicare, you're either gonna, that's where you meet the fork in the road. Once you've enrolled in, you have your Part A, because we've prepaid our Medicare taxes, and then you have your Part B, and they're both gonna be in effect. That's when you hit the fork in the road and you have to decide between a Medicare supplement and a drug plan. So with that scenario, your original Medicare is your primary medical benefit. You can add a Medicare supplement to back it up with secondary coverage or fill in the gaps. A lot of people refer to a Medicare supplement as a Medigap plan. Those are synonyms. And then original Medicare nor the supplement cover prescription drugs. So then we add a third card, which is your prescription drug plan. So you would have 3 cards in that scenario: original Medicare, your supplement, and your drug plan. And then alternatively, you can look at Medicare Advantage plans, but it's an either or. You're going to go one way or the other with that choice.
How do you help people determine that? I mean, that's just, I think it seems overwhelming to somebody to say, okay, well, how can I make decisions about which of those 2 pathways I need to get on?
So we want to make sure that they know how both scenarios would work. Sometimes they'll give us a lot of what if hypotheticals, which you could go days answering, because nobody really knows. If we knew the answer, it'd be an easy answer to decide. You go here, you go here. We kind of let the client dictate that, but more so it's showing how each works. So if we did, I met with a gentleman last week and he had a recent hospital stay, and I was out, his home health nurse wanted me to come out and explain the other side, the Advantage side of it, because he was looking for some additional benefits. So I want to make sure that he was aware of how his current situation worked, his Medicare and his Medicare supplement, and then how that same hospital stay that he just had would have worked with an Advantage plan. So a lot of times if you use, personal situations that they've run into, it's easier for them to grasp one way or the other. But again, there's really no right or wrong answer to which way they want to go, just as long as they know how both scenarios would have worked, what their expected cost should have been.
And I think the cost to those scenarios.
Yep, exactly. So he knew with his Medicare and his Medicare supplement, he went in, his Medicare paid the first 80%, and then his supplement picked up that remaining 20% that he would have been billed for had he not had the supplement plan. So as far as he knows, all of his bills were paid for. Now he was paying a monthly premium for that Medicare supplement plan. So he was essentially paying at some point, he just paid up front. Where that same cost on the Advantage plan, it was a little bit higher, a more upfront, here's a larger bill. But over over a couple of months, he was already paying that same amount out. So as long as he could see that money was getting paid out one way or the other, it's just more what they're comfortable with budget wise, or it's really just their comfort level.
I will say, for someone that's new to Medicare, one fairly straightforward scenario is if you've got someone that's, I'll use an example of cancer. So someone's got a cancer diagnosis and they're currently receiving therapies, and their Medicare is going to start next month, and they're deciding what type of coverage to utilize, and say they're taking an immunotherapy or a chemotherapy, whatever the case may be. In that scenario, we know that person is going to be a very high user of their medical benefits. And we know even what kind of treatments they're currently receiving and going to be receiving. So if you've got a chronic condition and we know we're going to have high usability, in that scenario, I personally would recommend for a family member of mine, original Medicare, a supplement plan G specifically, and then I would run their medications through Medicare.gov and choose the most cost-effective plan for their prescription list. but their Plan G Medicare supplement will say, would generically, I'll just around numbers. Every company's a little different on their supplements, but they would be looking at their Part B cost. Their supplement will round it to about $150 a month. And then their drug plan will round it to approximately $20 per month. So $170 per month on top of their Part B. And then the only liability they're going to have when they use their plan is the Part B deductible for the year. Where we sit right now, it's $204. So my patient example, so someone on chemo or immunotherapy, with the original Medicare, they're exposed to 20% coinsurance on all of those treatments. They're going to have an out-of-pocket of $200 or $204 for all of those treatments. And that's all they're going to experience for the year. But they are going to have that monthly premium to pay. But obviously, we know that monthly premium is justified because we know what it's paying for in the form of the therapies. For someone when we don't have that clear of a picture on the usability, when we've got a 65-year-old that's in relatively good shape, there's no right or wrong answer between supplement and Advantage plan. And I used to, when I first started doing this about, I guess, a dozen years ago or so, back then Advantage plans were not what they are today. So back then I would easily advocate for a family member of mine and say, if you can afford the Medicare supplement, that's what you need to do. But you fast forward to today, and my own mother turning 65 next year. If I'm being totally honest, she's in relatively really good shape, good health, minimal medication usage, no chronic conditions. She'll probably wind up with a Medicare Advantage plan and possibly some secondary coverage to the Advantage plan. Advantage plans have come a very long way in the last decade. And there's no right or wrong answer, but at the same time, I also have multiple uncles on Medicare. I always use my family members as examples. Two of them have an Advantage plan. One of them has a supplement. All of them started with supplements. If you asked the ones that have experienced both, they're still healthy enough to get their supplement back, but they choose to keep their Advantage plans. If that tells you anything, but the main point of that is supplement versus Advantage is get all the information as unbiased in an unbiased way as you can, educate yourself to where you understand it, and then you make the decision for yourself which one's better for you. Because without a crystal ball, knowing what's going to happen to our health,
We don't know.
right? There's no right or wrong answer. There truly is not.
And when you say, I think you might have touched on this earlier, but when you say unbiased, you mean that you are independent of any of the insurance plans, or unbiased means that you're just giving that patient the information. You
Correct.
don't-
Yeah, so we would
Educationally, yes.
Yeah, we would take a look. For us as a broker, we make a commission from any insurance policy that we sell, like any other insurance agent. There's commissions involved. But to us, Medicare dictates what a company can pay on their policies. So for us, it wouldn't matter if you were with insurance A or insurance B, they're both paying us the exact same. But we are able to offer insurance A or insurance B, depending on somebody's situation. There might be another insurance agent that only is contracted and certified to sell insurance A. So regardless of the situation that their clients encounter, insurance A is going to be the one and only answer, because that's the only option that he has, that he or she has to offer that client. So unbiased too, we don't want to, it's always going to be this, supplement route. You got to go supplement because that's the only way medical bills get paid. That person should know how both options work, be able to clearly explain that, so that their client has a better understanding of it. So if they're unsure, we still want to make sure that they know what they're signing up for, what plan they're agreeing to, and the consequences of either enrolling in a supplement now or delaying that. We just want to make sure that they're aware of any outcomes of the decisions.
There's also biases, and so there are lots of government programs you can enroll through and resources you can seek out. There are nonprofits you can seek out, and there are good and bad ones of those as well. So we've run into many instances where there's, say, nonprofit counselors that help people make their decisions either when they're aging into Medicare or on an annual basis to make their decision for what plan is best for them. There are some of those that'll just outright exclude all of Medicare Advantage, and they'll run your medications through all the Part D programs and help you choose a drug plan. And then those people unfortunately don't get all the information on the Advantage plans and don't get that option to choose whether or not that might be right for them. A specific example I can give on that would be, we had a scenario where there were two social workers working for the same entity that both wound up giving some advice to the same young lady that wound up being our client in the end. But one of the social workers said, all Medicare Advantage plans are bad. All you need is original Medicare. The other social worker that was with the same entity said, Sally, you need to, I can't speak to Advantage because I don't know enough about it, but here's all the information on original Medicare and drug plans. Go seek out, she sent her to us to get information on the Medicare Advantage plans. Well, I'm just using Sally as a generic name. She wound up being eligible. She had no teeth. So she had no teeth, and all of her medical providers were in the network. All the care that she needed was in the network. And then there was a dental benefit embedded in an Advantage plan that paid for her dentures in full from SureFit Dentures. She also had a lot of issues getting around to her medical visits and providers. It also had an unlimited transportation benefit. So she wound up with a set of dentures and unlimited medical transportation to all of her current providers that were also in network for the Medicare Advantage plan. And she literally walked in our office crying after she got her dentures from the denture manufacturer down the street that we referred her to. She didn't lose any benefits, any access to care, and she got a big part of her life back of being able to walk in our office and smile and eat solid foods. So it's very, I do a lot of times, I don't want to say that I'm biased towards brokers or towards nonprofit or against. I think there's good and bad resources everywhere you turn. You just want to make sure that no matter who you're talking to, that you feel like they are speaking to all of your options without trying to pull you one way or the other. Like they're just, I want to educate you to the point where you're comfortable making your own decision. That's the goal.
Yeah. And just somebody, well, who like you both, I mean, this has been really helpful to give a very clear overview of what Medicare is, when you're eligible for Medicare, what the choices are, that there are costs associated with both. And you have to really understand that so you can choose the best policy for yourself. Because really, you're the one who has to pay for it. So Medicare Advantage, and we're not going to spend a lot of time on it because I think most case managers, care managers, and patient advocates understand the insurance side. What they don't understand a lot of times is Medicare, traditional Medicare, but Medicare Advantage with being like an HMO or a PPO, and which one is better than that. So I know you put a lot of work into explaining that. Anything really important that people should know about the difference between like an HMO and a PPO, or?
Yes. So, HMOs, that's Health Maintenance Organization, and those have what I'll refer to as a closed network. So you have to use their contracted providers and facilities. PPO still has a network, but it's a preferred provider organization. So it's an open network. So they have their list of contracted providers and facilities. But additionally, if you want to go outside of the network, you still have out of network benefits. So with a PPO, you can truly go anywhere and receive care because you can utilize your out of network benefits. Every time I meet with someone who's turning 65 and we're talking about this piece of it, PPO versus HMO, I always use my father. He passed away on Easter Sunday, 2019. He had 7 separate cancer diagnoses in a 5-year span. So just he did not make it to age 65. He passed at age 60, but I always use his, crazy situation as an example of advising people on their Medicare benefits with a PPO. So my dad lived in the Louisville area. He had stage 4 bladder cancer. He decided he wanted to seek out what's called the IU pouch. So for bladder cancer specifically, some of the best care in the world is in Indianapolis, Indiana. They call it the IU pouch. It's where they surgically remove your bladder, make up an artificial bladder out of your own intestines, reinsert it in, and hopefully along with your bladder removal comes the cancer removal. It solves the problem and allows the person to continue on in life without having a pouch, an external pouch. So with a PPO in that type of a scenario where the best care in the world doesn't necessarily mean it's across the country, it can be a 2-hour drive from Louisville to Indianapolis. So with a PPO, that guarantees you the option to go seek that best care in the world that's 2 hours up the road. Or it could be even closer. It could be across town. He also had melanoma, and we seeked out care in Nashville, Tennessee. We also flew down to the Mayo Clinic and seeked out care in Jacksonville, Florida.
Who did all the research?
Luckily enough for me and my mother, my wife did about 90% of the research on where to go get all of this care and how it was going to work.
She did she's a care manager.
Yeah, she morning and night was constantly researching his different types of cancer.
Wow.
He had several different types of colon cancer, neuroendocrine carcinoma. The list goes on. He had stage 4 melanoma. Most of them he beat. Neuroendocrine carcinoma was the one that got it. But the point of all of that is if my dad's situation and we were willing to do anything we could within our means to get him the care he needed, if he would have had an HMO,
You would have been.
and that IU facility wasn't in that HMO network, we weren't going to have access to that best care in the world that was easily accessible 2 hours away.
Yeah.
So if PPO is an option for us, I strongly believe in utilizing a PPO so that we have access to those out-of-network benefits. And that's not to say that HMOs are never an option. They can be an option, but we are always very clear when we're utilizing an HMO on checking all the providers, making sure that all of your current care is in network. And then we also very much explain to our clients, here are ways to make the jump from HMO to PPO should the need arise. So a lot of people don't know that you can choose an HMO during annual election period. So hypothetically, say someone sees an added benefit they really need, and it's only on an HMO, they can go into that for January 1. So there's also open enrollment period that runs from January 1st to the end of March every year, where you can jump from Advantage Plan to Advantage Plan. So somebody might enroll in an HMO to get that benefit that they really need to utilize. Now the carriers are not going to like that I'm saying this.
Yeah, right.
but then that person could
That per member per month is important.
yeah, they could use their OEP before the end of March to transition over to a PPO for the remainder of the year, should they choose to do that.
And is there something with star ratings that gives carriers the ability to waive that?
So if they're a 5-star rated plan, you can enroll in that plan any time of the year under a 5-star special election period. The star rating system is the quality. So it's a measure of the quality of the plan
Yeah.
and their metrics. It's their scorecard, if you will. It's not the end all be all. A 5-star plan is not necessarily always better than a 4-star plan, but it is to be used as an indicator of where the plan falls in CMS's star ratings guidelines.
But being a 5-star gives you a little more flexibility if you do need to change.
Yes.
Yeah.
There isn't one.
It's an advantage to their clients, I guess. Or
Exactly. So somebody might need to, along with the annual enrollment period, everyone sees it October through December. Outside of that, there might be other life events. Somebody moves or they're discharged from a skilled nursing facility. All of those little events, they have the option now to switch plans if need be. So if they're now going to see a new specialist that's not in their current plans network, they're able to switch those plans. So they're not stuck in that plan throughout the year. So having that ability to switch plans, that's where that rolls in.
I would love to also point out to all your care managers, admittance into a rehab facility opens up a special election period.
Oh, really?
So if someone is say they're in a hospital and they're discharged into a rehab hospital or a skilled nursing facility, that immediately opens up a special election period to transition their plan. So
why is that? That seems from rehab. I wonder why that is.
I don't know what thought it was founded on. It's been around for a long time, but what we utilize it for is to set patients up for follow-through care after when the inpatient rehab is over, what providers are going to be in place after we leave the facility, and we need to make sure the current plan covers all of those providers and in the right manner. And if the current plan does not provide access to that follow-through care beyond the facility to make sure that the patient is not readmitted, we want to put a plan in place that does.
Oh, that's great.
Regardless of who you are and what your income is, if you're admitted to a rehab facility, you're in a special election period for your Advantage plan.
Oh, wow. That's
So
great.
as a care manager and advocate, if I have somebody that's in a facility and we're looking at providing care afterwards, and it looks like their benefits aren't going to cover certain things, that doesn't have to be the end of the conversation. They could actually evaluate some changing plans at that point.
Can somebody go straight? Do they have to go from the hospital to rehab, or can they go like somebody who really just is debilitating at home and they need rehab? Can they go into an acute rehab program and
with Medicare?
Yes, with traditional Medicare, yeah.
Not with traditional Medicare. You have a requirement to stay in a traditional hospital for 3 nights.
Oh, really?
And it's a 3-night stay, and observation nights do not count. And then now Medicare Advantage does allow for direct admit to rehab. But a traditional Medicare, you have to have a 3-night stay prior to being admitted to a rehab facility. Also, an example on that follow-through care would be say we've got a stroke victim that's now high risk to fall. So they've lost mobility, and when they get home from the facility, it would be really good to have, say there's a certain home health agency in the area that has a highly rated fall program, and you want to advocate for your patient to be able to be enrolled in and receive that care for the fall program. But they are in a plan that that home health agency is not in network with. But so upon admittance to the facility, you can work with the patient or somebody to get a plan in place to get that patient access to the fall program from that home health agency upon discharge.
Wow,
Just that's an example. That's one that we've done many times.
good. What about people that are in the military and they come out? They have some choices, Medicare, or can they go on the VA?
They get
You want to do it? Or?
yeah, they get the best of both worlds in a sense. So they'll have their Medicare, then get all of their care at the VA, prescriptions at the VA. But actually, I think all of the insurance carriers now offer some sort of veteran plan that's geared towards veterans. So with that plan, there's no drug coverage built in on that plan because it's still assuming they're going to get their medicines from the VA. But it does give them the option now to go outside of the VA for any medical care. So if there was a specialist that they need to see that's taking a long time for a VA specialist to open up, they're able to go and see that with that external.
Yeah, that Mission Act, I think is what you're referring to, the Mission Act. It was legislation to expand services for VA into private.
Okay.
Yeah, the Mission Act.
Yes, and this was so the Medicare Advantage plans that were designed for the veterans, even prior to the Mission Act, was a way to give them options outside of the VA. One thing that a lot of veteran service officers will refer patients to us as well, but the VA doesn't give a lot of advice, let's just say, to veterans on, so they don't have to have Medicare Part B. So for a veteran, so they're going to get Part A because they've paid their Medicare taxes and qualified, but they do not have to have Part B because their VA coverage is considered credible. So they can defer their Part B without penalty. But there's not a lot of education that goes on with veterans explaining the reasons why you might want to choose to take Part B, because it is going to likely cost them a premium that would be deducted from their Social Security check. But if they take the Part B, then that gives them a lot of freedom. So they can choose to use their Medicare benefits or their VA benefits. They can enroll in Advantage plans that have additional benefits beyond what Medicare provides. It opens up a lot of options for them. Some of them can also get their Part B paid for. And they may not know that there's a program out there to where they can accept Part B and get it covered. So there's a lot of, unfortunately, there's a lot of things that go unspoken or uneducated to the veterans on what their options are. There's also TRICARE and CHAMP VA.
Yeah.
I don't recommend considering an Advantage plan for someone with CHAMP VA, but for TRICARE, there are programs that can be considered.
And they're for veterans or for active military? TRICARE, I guess I was TRICARE.
So TRICARE and CHAMP VA, it all works in accordance to how many years of service and their status they've obtained in the military.
And some will cover their family members and things like that as well.
Okay, yeah. One thing I saw that you wrote on your notes, ignore all unsolicited phone calls. I know when my husband was ready for Medicare, I could not believe how many phone calls we got.
He was on the list, the turning 65 list.
You know, who gives that list out? You know,
That's a good question. And I assume you all got a bunch of mail.
Almost every single day, we would get 5-6 calls a day.
Yeah.
We know you're turning 65. We want to talk to you about insurance. It's like, how did you, I just really, I said, you must be on a list, like they know you're, and it was for months.
So Medicare, just remember they're a government agency, and kind of like the IRS. A lot of people know that the IRS will not call them.
Yeah.
They'll send you a letter in the mail. Same thing with Medicare. So there are tons and tons of phone calls and scams and or where they'll tweak words and situations where they'll call and make it sound as if it's Medicare calling. They will
Yeah.
never call you. The government or Medicare is not going to reach out to you via phone. Those are all either carriers or brokers or agents of some sort, or worst case, it's a con artist. Medicare is not going to call you to talk to you about your benefits.
They're going to mail you the Medicare and You book, and that's about as far as they'll go with it.
So can you speak to, for somebody that may not be familiar, what's the difference between a carrier and a broker approaching you?
So the carriers, so Humana, Anthem, United, et cetera, they all have internal salespeople. So that'd be, a carrier, they have telesales, and then they also have agents that'll meet with you one-on-one and in person as well. But that would be someone that works for a Humana, as an example, that's reaching out to enroll people for Humana.
Yeah. The carrier is just the insurance company. They're the insurance carrier. So that's the big company. Where a broker
has a contract with all of the carriers to offer all of them.
Yeah. Okay.
So if I'm dealing with a carrier from United or Humana or one of those companies calls me, they're just going to be interested in selling me their plan. Is that
absolutely
accurate? So,
yeah.
So I would, to compare, I'd have to talk with all of them, or
Correct.
I could go find a broker that sold multiple Advantage plans to help with that. Okay.
So you could go into like one way to do it would you could go into Medicare.gov, type in your zip code, and look at all the available Advantage plans. And then if you reached out to a broker, you could read them off, and you could say, hey, do you offer Humana? Do you offer Anthem? Do you offer Cigna? Do you offer WellCare? Do you offer, you can list them off, and if they check all the boxes for you, you would know you're talking to somebody that's offering all plans available to you in your zip code.
Wow. Boy, we could spend another hour or two.
Mhm.
And,
Yeah,
and I
but
know you guys.
have you back.
Yeah, really.
Yeah.
I mean, this is just, it's so overwhelming, but this has been so helpful.
The unsolicited mail probably came to you along with the phone calls. Did you get that as well?
I don't remember seeing as much mail.
Okay.
And maybe it didn't hit us because we do get a lot of junk mail.
Yeah.
And so maybe that, but the phone calls were over the top.
Well, and I would recommend to everyone, take your time. If you're turning 65, you have 7 months to make your decision. If someone sits down and explains it all to you and they want you to decide that day, you probably need to look another direction. If you decide you're ready to enroll day one, that's just fine. But don't let someone tell you that your time is limited. You've got a 7-month window to make this decision. 3 months before your 65th birthday, the month of, and 3 months after. So just get educated and make your own.
And that's where Medicare will send you information that you're going to, that's where Medicare sends you the information.
Correct. Yeah.
Not calls you, but sends you.
Yes.
And then Medicare.gov is the #1 website that people should go to learn about Medicare.
.gov. Medicare.com will take you to a broker.
I'm sorry, I meant Medicare.gov, yes.
Yeah, but it is, I was just clarifying that. No, you said .gov, but I want to make sure people are aware that it's .gov and not, because Medicare.com does exist, and you're going to get brokers and basically they'll sign you up for a plan. Okay. Medicare.gov is going to be personalized to you, give you all the plans in your area. That's the official government website there.
And we'll have a link to the Medicare Made Clear piece that we kept referencing, and then we'll have that on our website. We'll have the Medicare.gov link and a couple of other resources on there, but our website is seniorba.org. So
I'm sorry, you guys do you just serve Kentucky, or are you in other states?
We do a lot of other states at this point, especially since virtual is becoming more and more popular. Some bigger provider groups that we work with have asked us to do. We do North Carolina, Louisiana, Texas, West Virginia.
Are you in
think-
Florida?
I personally am now in Florida because of several requests during annual election period. Have not figured out how to license the agency in Florida yet. There's a few hurdles, but I am working on that. So that'll happen at some point this year. But I personally can assist in Florida. I think there's one of us here in the office, Miss Heidi.
Ohio.
Heidi can do Florida as well. Ohio, any state that we would need to operate in, we can. And now that virtual is taking such a leap forward, all the carriers have tools in place for us to be able to assist people with enrollments just about anywhere in the country. But if it's a state we don't operate in, it's just a matter of us applying for a license with the state. And it's usually a matter of days or weeks, worst case, to get set up to do it.
You know, I was going to ask you about that because that's where I think case managers and advocates would recognize. But you as licensed brokers are licensed in the state. So that's a sense of security for somebody that you're working with a licensed broker, just like we have to be. Many of the care managers are licensed nurses, licensed social workers. And I could work in other states too if I had a multi-state license, or So yeah, that's similar to what's in our field too. So that's good to know that that's an important piece. So thanks everybody for participating today, joining us on our podcast. To George and Michael for their time, and for Ginger for sponsoring this as My Care Alliance. And Ginger, did you have any closing remarks?
No, I just, I hope that this has been valuable for our members to be able to listen to. And please know that if you want to contact George or Mike directly, or get information from them as a resource, they are available, and we can certainly connect them with you. Or if you want to hear more information, you had other questions about Medicare, these guys know what they're talking about. So we'll be glad to invite them back.
Great. Thank you. Have a good day.
Thank you.
Thank you so much.